what I'd like to do today, I was actually asked to talk to you about the Seattle heart failure model. The Seattle heart failure model is a multivariate risk score that's like the Framingham model, and I call it Framingham on steroids for heart failure. The difference is, unlike Framingham, in Framingham you cannot alter risk. You can say somebody's high risk, and because they're high risk we should do X, Y, Z, but then you can't show the patient how much longer they might live, how much their infarct risk might go down if you put them on a statin, you put them on an aspirin or other things. With the Seattle heart failure model, you can do that. I've been fortunate to have research support for both the Seattle heart failure model and participating in other trials, and the UW Tech transfer holds the copyright to the Seattle heart failure model. It's not held by me, it's held by the university. And I'll be discussing on-labeled our investigational uses of drugs, specifically statins in heart failure. So you have a patient who walks into your clinic, okay? 63-year-old male, ischemic cardiomyopathy, does not have angina, functional class 3 symptoms, ejection fraction is 20%, blood pressure is 120/70. He's on lisinopril 10 twice a day, carvedilol 12.5 twice a day, which is now generic and available from Walmart or Target for $4 a month. So the price problem should no longer be an issue even if they don't have insurance. Lovastatin of 40 a day, furosemide of 120 milligrams a day, and has a QRS width of less than 120 milliseconds. And if you have not gotten used to looking at the width of the QRS in somebody with functional class 3 R4 heart failure, start doing it. We now have special pacemakers that can make symptoms improve dramatically and cut the risk of death by 1/3 if you use them, and we'll talk about those briefly as well. This patient is typical for the treatment group of a trial called Copernicus, which was carvedilol on top of an ACE inhibitor in severe heart failure with an annual mortality of 11%. 11% would suggest that treatment with drugs and devices like an aldosterone blocker and an ICD would be very appropriate. Transplant, probably not. LVAD, absolutely not indicated. But it is difficult as a clinician to put everything together and to make these decisions. If we go to Braunwald's textbook of medicine, these are all prognostic predictors in heart failure. But even if you know every single thing on this page, you cannot predict prognosis for a patient. Nobody has built a model with all of these variables that you can plug them in and say this is the patient's risk. Now what's missing on this page is what we do all the time. That is heart failure medications and devices. We alter their risk by treating them by guidelines with ACE inhibitors, beta blockers, aldosterone blockers, and statins in appropriate patients, and devices like BiV pacemakers and ICDs. Those alter the risk substantially. We have proven that in large, multi-center, randomized controlled clinical trials. This is not surrogates of blood pressure, that my blood pressure drug is better than yours because it decreases it. These are outcomes of mortality that we have for almost everything we do in heart failure. Biomarkers are very sexy in heart failure. You can measure things like TNF-alpha, the receptors for tumor necrosis factor, which is elevated with lots of inflammation. You can measure interleukin-6, or you can measure the response from interleukin-6 called C-reactive protein. You can also measure one biomarker, which I think is very powerful, called B-type natriuretic peptide. Now, all of those are generally research things short of BNP and C-reactive protein. But we can measure things that we commonly measure on most of our patients, or you certainly can measure them in your clinic, and these are some of things that I call biomarkers. Serum sodium. Serum sodium reflects activation of the sympathetic nervous system, also reflects activation of the renin-angiotensin-aldosterone system, and reflects if people have diabetes with high glucose, their serum sodium goes down. Low serum sodium is bad in heart failure. Cholesterol is reverse epidemiology. Cholesterol is a negative acute phase reactant. We see this when people come in with their acute infarct, their C-reactive protein goes up, their cholesterol goes down. People have sepsis. They have a cholesterol of 200, they're septic, it's 80. In chronic heart failure, you have low-grade ongoing sepsis, we call it inflammation, and their cholesterol can be very, very low. So low cholesterol is bad in heart failure. That has led some people to say we should not give them statins because we lower their cholesterol. I don't personally believe that that's true. High white count can be a measure of inflammation as well, and also a measure of norepinephrine, or the sympathetic nervous system. Lymphocytes, the differential count, and we're looking at the percent of lymphocytes on the differential. Low lymphocytes is a marked risk factor. People who are in the hospital very sick with heart failure may have lymphocytes of 10 or 15%. Chronic outpatients may be in the 25%. Most normal people are around 30%. Hemoglobin is a marker as well. It reflects renal dysfunction. It reflects cytokines. It can also reflect smoking or lung disease with polycythemia. Most heart failure patients are anemic. We do not know if treating the anemia is beneficial. We're doing a trial with that with darbepoetin, which is a research trial. If you have anemic heart failure patients, functional class 2 through 4, EF under 40, with hemoglobins in the 9 to 12 range, iron saturations of 15% or above, we'd love to see them. Randomized between darbepoetin and placebo for morbidity mortality outcome in about 3,500 patients. We don't know if that's beneficial. We're testing it. We've done pilot trials. Unlike other ones in kidney disease, these pilot trials have suggested about a 25% reduction in morbidity and mortality by treating anemia and heart failure. If you have high hemoglobin, I think of sleep apnea or lung disease. If people walk in your clinic, their hemoglobin 16, ask about sleep apnea, you will probably get a positive history from the spouse that they stop breathing, they try to wake them. Treating their sleep apnea can improve ejection fraction as much as 10 points. B-type natriuretic peptide reflects stretch on the heart from volume or from size. It is a very simple measurement that can tell you whether somebody's high risk or low risk. It can also, if you know what their dry BNP level is, it can tell you whether or not they are dry or wet. The problem is that people can be perfectly dry, euvolemic with normal wedge pressure and CVP with BNPs of 1,000. So you have to determine what is their normal BNP level for that patient and whether they've gone up or down from that level for them. Renal function is a marker of inflammation, perfusion. We call it the cardiorenal syndrome. Cytokines can worsen renal function as well. The ones that are in the cyan color are the ones that are in the Seattle heart failure model, and that includes uric acid. Uric acid goes up in heart failure. Years ago, gout was noted to be associated with coronary disease. Well, it's associated with cytokine activation, with diabetes, with renal dysfunction, and it also correlates with impaired flow-mediated vasodilatation, the ability to dilate your blood vessels when you exercise. Here's peak oxygen consumption. We used to use this routinely for trying to decide if somebody needs a transplant. We don't use it as much now as we did. But the cut point was 14, and you can see on the left side the above and below 14. On the right side is using just functional class, which you ascribe clinically, talking to your patient in clinic, whether they're functional class 2 or 3. Either one works equally well. Here's a very simple risk marker. This is data I presented 5 years ago at the European Society of Cardiology from the PRAISE trial, which was severe heart failure, and looking purely at how much diuretics they needed to take. These are all functional class 3B4 heart failure patients, ejection fractions under 30%, preceded treatment with beta blockers, so ACE, DIG, diuretics. People who were on low doses actually were low risk. The black line, 10% annual mortality or so, or 20% is pretty low risk. The pink line is people who are on 300 a day of Lasix roughly. Those patients are very high risk. Those are the patients who may benefit the most from referral for additional care. This is the hazard ratios associated with diuretics, which is the most powerful variable in the model, followed by low blood pressure, low lymphocytes, by hemoglobin, then uric acid, and then other things. And you can build a model based upon this. You take the sum of the scores, you have something called a baseline survival function, you exponentiate it, and you come out with a predicted risk. So here is the trial it was based on called PRAISE, dividing it up into what's called deciles, about 110 patients in each dot. In a perfect fit, the predicted survival on the y-axis and the actual survival on the x-axis would be right on that line of identity at 1 and 2 years. This is what should happen if your model works in the database you built it in. And it works reasonably well, which it always will if you have a reasonable model. Now the ROC is how accurate it is in predicting outcomes. ROC of 0.5 is chance, flipping a coin. ROC of 1 is perfect. This is in between. ROC for the Framingham model is 0.73, so it's identical to Framingham, but now we're predicting mortality rather than predicting an infarct. And this is just looking within the databases that I collected at whether or not you are on 0, 1, or 2 or more heart failure medicines, ACE and a beta blocker. And what you can see is that you have a functional class 4 patient on 2 drugs has the same risk as a functional class 3 patient on 1 drug, or a functional class 2 patient who's on no life-saving medicines. It's extremely important to have them on the drugs, and it makes a marked difference in their risk of death. The first column is the randomized clinical trial benefit for being on an ACE inhibitor, a beta blocker. The ones that have been proven to be beneficial are metoprolol, bisoprolol, and carvedilol. That's it. Make sure they're on one of the 3 drugs. Bisoprolol is not FDA approved, but it certainly has been shown in a trial, and they decrease mortality about 34%. ARBs are about half as beneficial as an ACE inhibitor. So if somebody can tolerate an ACE, they're generic, they're cheap, have them on the ACE first. Have them on the beta blocker. I generally add the aldosterone blocker as my 3rd drug, and I use the ARB for people who are intolerant of an ACE inhibitor. I would still use statins in people who should be on statins. Ischemics, people with elevated cholesterol, people who have elevated risk of an infarct, those are the patients I would certainly have on a statin, including your diabetics, because of the trial showing substantial benefit in your diabetics. The beta blocker at $4 a month for Corveg or for Toprol or any of those reduces mortality as much or more than a device does. But the devices can be added on top of all of the medications. The benefit of your drug is reflected in lowering the blood pressure. In heart failure, that's not true. LVADs reduce mortality by about 50% and can be used when everything else has failed. So we applied it prospectively to 10,000 patients from 5 different databases. And here is about 1,000 patients in each dot. But the predicted and the actual outcome for groups of patient is extraordinarily good. That doesn't mean it's right for the individual patient. So it allows you to risk stratify, but it doesn't really predict for the individual patient how they're going to do in the short term. So what we have up here is survival at 1, 2, and 5 years. We have mortality, depending whether you're an optimist or a pessimist. If you integrate the area under this curve out towards their whole lifespan, you end up with their life expectancy. This is what I think patients understand. You're going to live about 7 years. It's hard for physicians and patients to really understand what does a 10% annual mortality. Well, you have a 10% chance of dying. Doc, how long am I going to live? That makes a little more sense. This patient, who's 63-year-old male, ischemic, if we enter him in the model, he has about a 10% annual mortality. We can add an aldosterone blocker on him, and by adding things, we go down here and click whatever you want to add. When you do that, you decrease his risk of death by about 30%, and you add 1.7 years of life by simply adding the drug. You can do it in reverse. A patient says, I want to stop my beta blocker. You on-click the box down here, and you'll see that they live a shorter period of time, and you can discuss whether it's worthwhile to live 1.5 years or 2 years less because of side effects from the drug. This is what it looks like graphically. This patient could be on any one of these curves. So how do heart failure patients die? If they are symptomatic in the hospital, in and out, they're short of breath walking across the room, they mainly die of pump failure death. A defibrillator in this type of patient may not alter their outcome very much. It may just change their mode of death from a pump failure death to, from a sudden death to a pump failure death. These are the problem patients. These are the patients who may be working full-time. They have a low ejection fraction. They feel invincible because they haven't been hospitalized for 5 years for their heart failure. They're on appropriate drug therapy, but they still have a substantial risk of sudden death every single year. These are the patients we need to talk into a prophylactic defibrillator because many of them do not think that they're at risk. If we look at the Seattle heart failure model, people who have a low score, this is roughly 5% annual mortality, 75% of their deaths were sudden death. This is around 10%, this is around 20%. Once you go above 20%, pump failure death becomes the primary mode of death. If we look at functional class 2, 3, and 4 here, people with low scores, 0 and 1, 5, 10% annual mortality, even if they're functional class 4, their primary mode of death is sudden death. So it may be appropriate to place a defibrillator in this functional class 4 patient, even though it's not indicated in functional class 4 patients, but the person is low risk. We don't know that, but it may be appropriate to do that. When you get into the more intermediate risk group, this is where you want to know if the QRS is wide because you may put a combination device of a cardiac resynchronization therapy or BiV pacemaker in combination with a defibrillator or by itself just as a pacemaker. When you start getting up here, this is where you think about LVADs. And so you say this patient really may need a left ventricular assist device rather than one of these other devices. ICDs in heart failure made it to ischemic cardiomyopathy, showed a 31% reduction in all-cause mortality with the defibrillator. Amiodarone was no better than placebo. It did not kill patients, and that is amazing considering that many antiarrhythmic drugs have been shown to increase mortality. So it's about the only antiarrhythmic we use, mainly for atrial fibrillation in our heart failure patients. What you really need to know is that with CRT, people feel better. And so it's easier to sell them on a CRT device than an ICD because ICDs don't make you feel better except to relax that you don't have to worry about the sudden death. CRTs, 2/3 of patients feel substantially better. We did 2 trials with these devices looking at mortality. The CARE-HF, the first trial, was only a pacemaker, no defibrillator, and over about 3 years of follow-up, a 36% reduction in all-cause mortality, marked improvement in symptoms, and improvement in ejection fraction and blood pressure as well. This was called Companion Trial. Companion Trial had medical therapy versus the pacemaker and a defibrillator in the blue line. The pacemaker alone at 1 year cut the risk of death by 24%, cut the risk of hospitalization by 20%. In combination with the defibrillator, it was a 36% benefit, hospitalizations reduced by 20%. So how do you model this? You can see it's grayed out. You have to check the box, and then you can either check adding a BiV pacemaker or adding a BiV ICD. And it will show you the mortality benefit. It does not show the symptomatic benefit. We do not know what annual mortality is necessary to list a patient for transplant. Donna Mancini, 18 years ago now, suggested that the VO2 had to be below 14, but at that time it was associated with a 25% annual mortality. Most people have suggested that the risk with the transplant should be about the risk without a transplant at 1 year. After 1 year, the risks diverge because you have the upfront risk of surgery, whereas after transplant, your risk of death is around 5 or 6% per year in the total population. LVADs. We don't know how to decide who gets an LVAD. The simple criteria was, I think the patient's going to live less than 2 years. EF is under 25%. That's what is under approval right now for the LVAD, but we don't have a clinical risk model to actually say, is the physician right in their estimate? And should a model like the Seattle heart failure model be used to help determine listing for transplant or LVADs or other things? This is theoretic curves. This black curve is the transplant survival in 52,000 patients. This is our transplant survival in 450 patients since we started in 1985. We are very proud of the fact that we have an 82% 5-year survival, and we have a 57% 15-year survival with heart transplants. People do very well, and our 1-year mortality is about 10%. We did a trial called Rematch, and we were fortunate to participate in this trial, and I've now applied the model to this database to see whether or not the model will work. What they showed with Rematch, which is an artificial heart, the device is placed in the belly, driveline coming out. You carry battery packs that last about 4 hours. You change the batteries out. When you're at home, you plug it into a base station. This is not a pacemaker. It's not wonderful where you put the pacemaker in and it has a 7-year battery life. These are significant change in lifestyle. This is the one that we are currently using as a bridge to transplant, and also we're doing a randomized trial between this device, which is about the size of a D-cell battery, and this device over here. And so they're randomized between it for destination therapy. And this device has a little rotor in it that spins at 10,000 RPMs, no valves whatsoever, and because there's really very few mechanical parts, this is thought to maybe last 5 years. This device, the pig valve starts to break down at about 18 months, and so it's not a great long-term replacement. This is the one that's approved right now for destination therapy. This is the research one. This is one called VentriAssist. It has a pump in here that's mechanically lubricated, and it may last even longer than this one. We may be doing studies with this one. This is the Jarvik 2000, which pumps into the aorta and is the true assist device, pumping only 2 or 3 liters. These can pump 10 liters. This is the trial we participated in where they used this axial flow pump as a bridge to a transplant. And this is my guesstimate here using the Seattle heart failure model, what their survival would have looked like without the device. This is the bridge to transplant. They had 68% of patients alive at a year. They had 75% alive to 6 months, which was the primary outcome. You have an operative risk of about 15%. After this, it appears this risk may go down into the 20-25% range per year. So here is looking at the model. The model does not have balloon pumps, which will triple their risk. It doesn't have inotropes, which will increase their risk about 20%. Those will be added once I get it published. But this is a high-risk patient. He's on an ACE inhibitor, intolerant of the beta blocker. He's on a statin, allopurinol, and a aldosterone blocker, 200 of torsemide a day. These are all higher risk. You can model what happens without adding an LVAD, and you would add 0.8 years of life. So what's the optimal therapy for heart failure? I think we need to block angiotensin II. We can use an ACE or an ARB for that. Block aldosterone with either eplerenone, which is a drug that's developed that does not have gynecomastia, whereas spironolactone, about 10% of patients will develop gynecomastia. The big problem had been the cost. It was $100 a month. It has gone generic. I haven't heard if anybody's making it available generic, but that may obviate it, and we'll just use eplerenone instead of spironolactone. Beta blockers, and as I talked about, metoprolol, carvedilol, bisoprolol are the 3 that I would use in heart failure patients. I think that statins may be the ideal agent to modulate cytokines. I'd love to have randomized clinical trial data showing that it improves outcomes significantly. Unfortunately, we don't have that yet. So heart failure medicines can reduce mortality by about 2/3. Adding a device can increase it to about 3/4. The Seattle heart failure model incorporates medicines and devices and simple markers, high-risk patients. The inability to tolerate or the need to withdraw heart failure medicines. These are all simple high-risk markers. Utilize the Seattle heart failure model to risk stratify patients. Less than 10%, think about defibrillators, CRT, along with all the usual medicines. 10 to 20%, think about those as well. Maybe the CRT first if they can get it. Think about transplant. Higher risk, maybe just a pacemaker without a defibrillator. CRT pacemaker or transplant greater than 40%. They'll likely be an urgent transplant or LVAD. These patients do not do well when they reach that risk. This could not be accomplished without multiple collaborators. I've been fortunate to be able to get access to databases by Pfizer, by Merck, by Amgen, Novartis, and Medtronic has provided support for the model. And Dari Mozafarian, who was a fellow here, is now at the Harvard School of Public Health, has been very helpful, and David Linker by doing the programming to make it available to healthcare providers. We were fortunate. We had it profiled in Archives of Internal Medicine under palliative care. We had 50,000 hits on our website in 3 days. We've had over 5,000 people download the model to run it. We've had about 20,000 people run it on the web. And so it's actually reached high level of penetration into the cardiology community, and hopefully it can reach the primary care community as well. Thank you very much.
Okay, I'm going to talk about 64-slice cardiac CT, how we do it, how we use it, and I'll just make my conflict of interest statement. I do get a grant from General Electric Healthcare to support clinical research, but it doesn't apply to salaries, and I'm not advocating any particular type of scanner here. What we're going to talk about are the advantages of 64-slice CT scanning, which is the latest technology, and why that has been a major breakthrough and why that has really made cardiac CT a viable force in the clinical arena. We're going to talk briefly about how to perform a cardiac-gated CT. I think you'll find this interesting. I'll try to keep the technology part of it minimal. We'll talk about the appearance of coronary stenosis on CT images and the concept of vulnerable plaque and how that may be an area of very interesting research in the coming years. We'll talk about the use of whole chest EKG-gated CT, that is going from the top of the lungs to the bottom of the lungs as opposed to just doing the heart. And we'll talk about current and evolving indications for cardiac CT as defined by the American College of Cardiology. Well, change is inevitable, as Groucho Marx said. And this has been a big change in the field of cardiac imaging. We don't know what the full impact of this technology is going to be. But it's clear it's going to have a very significant role in certain very focused areas. Why 64 and why has this made such a big change? Well, it's because it's different in spatial resolution, in temporal resolution, in coverage, artifact reduction, and dose reduction. And I emphasize this latter, dose reduction, because this is something that both the lay public and the medical world is becoming far more sensitive to in the United States. We're sort of catching up with Europe in that regard. What is our spatial resolution? Well, we're talking about seeing structures now that are well below a millimeter in size. We're talking about seeing tiny little coronary arteries. We're talking about seeing SA node vessels, for example, as opposed to seeing the main coronary arteries in their side branches. So our spatial resolution has become much greater. We used to talk about 1 line pair per millimeter. We're now at 4 line pairs per millimeter. And so this is a substantial change from merely 3 or 4 years ago. Temporal resolution is critical when you're imaging a moving structure like the heart. I'm sure all of you any of you who've done photography in the old days of film remember that if you shot a picture at a 50th of a second, you got a fair amount of blurring, but if you could get up to a 100th of a second, you could freeze a lot of pretty fast motion. And if you got up to a 500th of a second, you were really very capable. We're well above a 100th of a second in terms of our ability to freeze motion now. The rotation time for the scanner is about 0.35 seconds, but we only use half of that, so 0.175 seconds, so about 170 milliseconds is our temporal resolution. To cover the whole heart now takes about 5 seconds, which is roughly 4 to 6 heartbeats, and it takes only about a 5 to 7 second breath hold. Why would the breath hold matter? Well, it's because your heart rate varies as you're breathing. And in fact, if you take in a big breath and hold it, initially your heart rate will go up for about 2 seconds, then it drops back down to baseline, stays stable for about 5 seconds, and if you keep holding your breath, your heart rate starts varying all over the place. Well, our ability to make images, or high-quality images, depends on a steady heart rate primarily. And so this is our window of opportunity right here. It's about 5 seconds long. And so we try to time the arrival of the contrast in the heart to hit right into this window, and that's all the time we need now to do a cardiac scan. Coverage, well, we can cover not only the whole heart now, but the whole cardiovascular structures of the mediastinum, if you will, in a single exam. And so there's a greater extent of anatomical coverage per second. And what this translates into is the ability to get through the heart in that critical 5-second period. This is what our previous generation of technology could cover in 5 seconds. This is what the current generation of technology can cover in 5 seconds. And actually, there's a coming generation that will hit in about a year and a half that'll cover the chest and the abdomen entirely in 5 seconds. Artifact reduction, very important issue in the heart because of calcification. You've probably all heard about calcification in coronary arteries. These calcium plaques, when they're moving, can make a blurred, smudged, white artifact that's hard to interpret and see the lumen in the vessel around the plaque. But because of our better temporal resolution, our better spatial resolution, we now have much less blooming of the calcium, so we can see around the calcium and see lumen adjacent to calcified plaque. And that used to be a significant handicap in the previous generation of scanners. So even when you have somebody who has diffusely calcified vessels, like this patient, we still can assess the lumen around these vessels. Dose reduction. Well, we've been working in 3 different areas to get the dose down. One is you gate the scan to the EKG so that you actually vary the intensity of the beam depending on what part of the cardiac cycle you're in. Another is you vary the intensity of the beam as you rotate around the patient because the patient's much denser when seen in a transverse view than when seen in an AP view. And third, you do what's called prospective gating. And what that means is you look ahead, you guess when the exact best time is going to be to do an image, and you do a very brief snapshot at exactly that moment. And I'll go over that technique in just a second. So here's the concept of dose modulation based on the EKG. What happens is the intensity of the beam ramps up and down depending on the part of the cardiac cycle that you're in. And it's high during diastole when there's not much cardiac motion, much lower during systole, but still on during systole. And this is with a technique we call retrospective gating. The new technique called prospective gating basically has a whole different technology. With the retrospective gating, the beam is on the whole time during the scan. But with the prospective gating, the beam just pops on snapshot for a brief part of diastole, so it's only on for about 26% of the RR interval. The other thing that's different is with retrospective gating, the table's moving the whole time, so there's some blurring from motion. Here, the table is steady during the snapshot, and then during the intervening heartbeat, the table moves, and then we do another snapshot, another move, another snapshot. So it's a new technique that markedly reduces dose and improves our image quality. And here's some of the images from that new technique that we've been working with over about the last 6 months. And you can see we get very high quality images of the coronary arteries with this technique. So what kind of dose are we talking about for cardiac CT, and how does that relate to other types of imaging that we typically do for the heart? Well, if we use only the EKG modulation, we're talking about 6 to 13 millisieverts. Mind you, the recommendation for healthcare workers is that they get less than 5 millisieverts per year exposure. Background exposure for an average person in Seattle is about 5 to 7 millisieverts from natural radiation. If you work as an airline stewardess, you can get up to 50 millisieverts per year because you're up above the atmosphere for part of your working time. When you add the 2 types of modulation together, we can drop that dose down to 3 to 6 millisieverts, and when you use the snapshot prospective gating, 1 to 4 millisieverts. So we've really dropped the dose from the 10 millisievert range down to the 1 to 2 millisievert range over the past about year and a half in terms of refining this technique. So how does that compare to cardiac catheterization? Well, it depends on how many runs you can do, anywhere from 1 to 18 millisieverts for cardiac cath, typically in the 3 to 5 millisievert range. For radionuclide studies, stress exams, if you use thallium, 25 millisieverts. If you use sestamib, 12 millisieverts. So you can see these are very, very useful tests, but do involve a higher level of radiation. So what are the contraindications? On whom do we not want to be doing cardiac CT? Well, first of all, you have to have the ability to hold your breath for 5 to 8 seconds. You have to not be allergic to intravenous contrast, and you need good renal function. You can't have a marked arrhythmia. Atrial fibrillation is a contraindication because we need, again, a regular rhythm. And we don't want patients with classic acute cardiac chest pain with acute coronary syndrome in our scanners. We want those patients in the care of a cardiologist, usually in the cath lab. Again, coronary artery calcification is no longer a contraindication, and the presence of a pacemaker is also not a contraindication anymore because of the better ability to deal with these artifacts. So how do we do a scan? Well, first of all, before scanning, you need to avoid caffeine because that raises your heart rate, and we want a slow heart rate. We give a beta blocker, 100 milligrams, usually orally, and then about an hour later scan. There are contraindications to the beta blockers, which are listed in your syllabus. And our goal in all of this is to try to get the heart rate down in the 60 beats per minute range, roughly 1 hour after you take the dose of metoprolol. And if we don't achieve this with this single dose of metoprolol, there are things we can do like giving intravenous metoprolol or adding more PO metoprolol, but that's less than 5% of cases. 95% of the time with a single dose of metoprolol, we get the heart rate we need to do a good scan. So why are we working so hard to get a heart rate below 60? Well, it does give us significantly better image quality because there's less motion blurring, but metoprolol also regulates the heart rate so that it's very regular and there's less beat-to-beat variability, and that's an important issue for EKG-gated cardiac CT. It also lowers the overall radiation dose to the patient. The slower the heart rate, the lower the dose. One other challenge is how do we time it so that our bolus of contrast is in the heart at the time that we do the imaging, because it's a short bolus given very quickly and it has a circulation time from the antecubital fossa to the coronary arteries. Well, the way we determine that is we first give a very small bolus called a timing dose, and then we do a series of scans at one level, right where the orifice of the left main coronary artery is, one slice every 2 seconds. And then we measure the density of the aorta. And if you do that, you can plot the density versus time. You see initially that the aorta is not very dense, and then it rises as the small bolus hits the aorta, peaks, and then drops off. And so this is the circulation time from the antecubital fossa to the coronary arteries, and in this case, it's about 14 seconds. So that's how we can determine for each individual patient what their circulation time is and get the bolus there at the right time. The other thing we do before starting the scan is we give a blast of sublingual nitroglycerin. A blast, it's one spray, actually. And the reason for this is to dilate the normal coronary arteries. This is a typical practice in the cath lab, and we want to simulate the situation in the cath lab. Then we get ready to do the main money run, if you will, or the important run. For that, we use what we call a triple bolus of contrast, a bolus of pure contrast, followed immediately by a bolus of a blend of contrast and saline, followed immediately by a blend or a bolus of pure saline, and all of it given at a fairly rapid rate, 5 cc's a second. And how do we do that? Well, we use what's called a double head power injector. One of these pistons is loaded with saline, the other is loaded with contrast, and these pistons can move at different speeds, so you can get different blends of saline and contrast. Now that sounds like quite a struggle. In fact, it becomes fairly automated after some practice with doing this. And we're doing it for a fairly important reason. What we're trying to achieve is a situation where our timing is such that we have saline in the superior vena cava, we have low density contrast in the right heart, we have very high density contrast in the left heart and in the coronary arteries. And the reason for this is in the right atrium, you have a mixing of blood from the superior vena cava and the inferior vena cava. The inferior vena cava blood has no contrast in it. The superior vena cava blood does have contrast because it's coming from the antecubital fossa. When those mix and swirl together, they can make artifact, and that artifact shoots across the right coronary artery and can compromise imaging of the right coronary artery. So this is what we're trying to achieve in our cross-sectional imaging of the heart here. Here, the left ventricle, left atrium, right ventricle, right atrium. And notice that we've got low density saline in the right atrium, mild density mixture of contrast and saline in the right ventricle, and then pure contrast in the left ventricle. And this is all a timing phenomenon, and again, with the aid of that timing bolus, we're able to achieve this virtually all the time. But also notice there's no artifact here being produced by swirling blood in the right atrium. There's the right coronary there. And this is what it looks like in the coronal plane. Here, the left ventricle, aortic valve, aortic outflow tract. But notice that in the right atrium here, we have low density contrast so that it's not making any artifact. Then we go ahead and do the enhanced CT run of the heart once we get the bolus set up. We first of all have the patient take 3 breaths in and out, ending with inspiration, hold their breath. It's all over in 5 seconds. It's a very, very fast scan. Usually the patients aren't aware that we've scanned them and say, ask us at the end of the scan, when do we begin? And here's just a picture of the scanner with a patient in the scanner. Notice that the tech is blurred here because she's sprinting out of the room because she stays with the patient till the very last moment to make sure everything's functioning properly, sprints out of the room. 5 seconds later, the scan is done. Now, all the information, we make about 1,400 slices through the heart during the course of one of these scans. All that information goes off to a 3D workstation. And in the 3D workstation, there's a lot of number crunching that occurs. And we reconstruct images at different points in the R to R interval of the EKG cycle. And the reason we do that is because the right coronary moves the least between 30 and 60% of the R to R interval. The left coronary between 60 and 80% of the RR interval. So they're at different times when they are optimally imaged. But we just make images during those different times, and then we can see all the coronary arteries optimally. The other thing the 3D workstation does is you just put a starting point in a coronary artery and tell it to go track the artery, and it tracks the artery, and we do that for each one of the vessels, and then we can display them individually. Here, a left coronary, circ, right coronary, and this is what a typical CT coronary angiogram looks like. We can display it in what we call the pathologist view, which is as if they had dissected the vessel out, laid it out flat, bisected it, and this is what it would look like in the straight lumen view. Now at the 3D workstation, we assess for stenosis, we look for plaque, we quantify the stenosis, we characterize the plaque, and I'll talk about that in a moment. But we also look at the rest of the heart, the myocardium, for function, focal infarction, aneurysm, chambers. We look at the valves on the left side of the heart. We can't see the valves on the right side of the heart very well. Pericardium and great vessels. So here's a patient with a LAD now. Here's a calcified plaque in the LAD. But one of the advantages we have is that we can rotate this image now through 180 degrees and look at that plaque from any angle. So we really have 360 different views of the plaque, and we can see it from all the way around. Here a plaque now that is what we call a mixed density plaque. It has some low density lipid areas. It has some dense calcification in the center of it, this one causing about 60% stenosis. I've just put this in to remind me to say that we can see much more than just the coronary arteries. Here the myocardium of the left ventricle, here's the mitral valve, and of course we've also got lung and mediastinum and aorta on these views as well. We can look for some functional information. This is not as good as echocardiography for functional information, but we can get some functional information. Look for wall motion analysis, ejection fraction, valve anatomy, and valve motion. And here's an example of a multi-image view. You can see the mitral valve here opening and closing. You can see the myocardium thickening in this normal patient who's got normal ejection fraction. But these are different views at different levels on the short axis view of the left ventricle. We can do ejection fractions, so you look at the volume of the left ventricle in systole and then look at it in diastole, subtract the two. This particular patient had an ejection fraction of 70%. This is a cast model, if you will, of the chamber of the left ventricle in diastole. And we can look at the valves. Here an aortic valve, opening and closing. We can assess coaptation, abnormal valve leaflet motion, look for calcification and thickening of the valves. We also look at the non-cardiac structures, the mediastinum, lungs, pleura, chest wall, bones, and then we send the key images off to the PACS, and from PACS, if you have the web version of our PACS, you can view any of this from anywhere in the world, from your office or from the hospital, clinics, wherever. I just put this in to remind me that we can see the pulmonary artery well here, so assess for pulmonary embolus. The aorta is present as well. And this little patient did have a small pulmonary embolus. Now, in the old days, we had a problem with unevaluable segments of coronary arteries. As a matter of fact, up to 20% of the segments that we looked at, we couldn't evaluate because of too much noise, too much motion, whatever. But with the new scanners, that number has dropped down in the published literature between 0 and 8%. In our experience here, it's around 2 to 3%. So essentially 98% of the coronary arteries are well seen and are valuable with this technique. So what kind of sensitivity do we get for looking for greater than 50% stenosis in the literature? In the old days, not bad. Currently, 94% sensitivity, 97% specificity. Probably the most important number, however, is the negative predictive value. And it's in multiple series with 64-slice CT. The lowest number I've seen published is 98%. The highest number, an unbelievable 100%, but it's somewhere up in those very high 90s. What do we do with stenosis? Well, we categorize it into fairly gross categories with CT. Again, we're not very precise in saying whether this is a 54 or 55% stenosis, but we try to put it into the categories that have some impact on what's going to happen to the patient. From 0 to 30%, we call it mild stenosis. These patients typically get treated with aspirin and statins, depending on their clinical circumstance. From 30 to 70%, we call this moderate stenosis. A number of institutions go from 50 to 70. We think there's some overlap between the 30 and the 50 categories, so we like to err on the safe side, and we call this moderate stenosis. Many of these patients get sent for some form of a stress test, either stress echo or stress nuclide test. Over 70% patients end up in the care of a cardiologist. So here's a patient who has a focal plaque, low density, high calcium center, this one causing pretty close to 70% stenosis. And here that same stenosis seen on cross-section. This is plaque, this is plaque, this is fibrous plaque here, and that's the residual lumen, is that small area on cross-section. Stenosis is a very interesting subject, but it's just one of the things we're looking for. In cardiac disease, is stenosis the whole story? Well, it certainly leads to angina, either stable or unstable. But we know that there's something of even greater consequence in the coronary arteries that causes roughly 50% of the people who die of coronary artery disease die with a sudden cardiac event without heralding angina. And this brings us to the concept of the vulnerable plaque and acute thrombosis, which is a different entity. I'm leaving the area of experience now and going into the area of conjecture and future research. And it's one area where I think the 64 and greater slice scanners are going to have a significant impact, at least I hope. Plaque rupture is the concept of sudden thrombosis resulting from rupture of the fibrous plaque or fibrous cap on a lipid plaque. And most acute coronary syndromes are initiated by this kind of sudden thrombosis on a vulnerable plaque. Now these plaques, when we look at them with CT, have a fairly typical appearance, and they have three characteristics. They have positive remodeling, that is to say they bulge out from the lumen of the vessel rather than into the lumen of the vessel. They have very high lipid content, so they're typically low density, and they typically cause minimal or even no stenosis. But they're characteristic in their appearance, and when you measure their density, they tend to be down around 40 Hounsfield units, whereas fibrous plaques up around 130 Hounsfield units, and calcified plaques higher than 150 Hounsfield units. So we can look at their density on CT and characterize them. Here, a fairly typical vulnerable plaque. Notice that it's bulging out from the lumen of the vessel here. This is low density throughout. It has no calcification, and it causes only minimal stenosis. And again, we can look at it from any angle with the 3D depiction in cardiac CT. So cardiac CT can detect these three characteristics which characterize vulnerable plaque. Possibly these patients do need to be treated, at least some of them. Intensive statin therapy, for example, may be an option in some of them. So detecting them probably will turn out to be an important issue from the standpoint of therapy. Well, we also use 64-slice CT not only for the heart, but also for the whole chest. And that is typically in the emergency room where we do what's called the triple rule-out exam, where we're looking not merely for coronary artery disease, but also for disease elsewhere in the chest, because the pain is nonspecific. We also look at the whole chest for evaluation of bypass grafts, because many of the patients with bypass grafts have Lima grafts that start up in the subclavian region. We modify the technique for the whole chest. We change the volume of contrast to a larger volume. We change the blend, and we change the delay time in order to get the whole chest scanned. The triple rule-out that I mentioned before is something that's being evaluated in at least 10 centers around the country now, and we're one of them. It's basically to deal with the issue of chest pain in the emergency room and try to differentiate with CT among cardiac disease, pulmonary embolus, or acute aortic syndrome involving dissection or aortic ulceration or interstitial hemorrhage of the aorta. But we can also see with CT pneumonia, pleurisy, mediastinitis, pericarditis, rib fracture, pneumothorax, the other entities that can cause atypical chest pain. This is a big issue. There are 5 million ER visits per year in the United States for chest pain. Of these, only 15% will turn out to have an MI. And of those who have an MI, roughly 10% will be sent home in error because it's a challenging diagnosis. Of these 5 million patients who visit the emergency room with chest pain, 60% of them get admitted for somewhere between 24 and 48 hours, and there's a substantial cost associated with this. So again, we can see the whole chest. We can evaluate not merely the ventricle and the coronary arteries, but also the whole aorta and the pulmonary arteries, looking for things like aortic dissection. Here, a big saddle pulmonary embolus, pleural effusion. So we're really seeing much more than just the heart. But the coronary artery exam in this technique is not compromised. And so we get just as good an evaluation of coronary arteries with the whole chest technique as we do with the heart technique. Again, plaque, focal, calcified, low density, causing about 60% stenosis. So our research protocol is to try and answer the question, can we safely discharge from the emergency department much sooner based on a negative CT plus negative cardiac enzymes and EKG? Our preliminary data suggests that we can cut the time of the patient's length of stay in the emergency room by at least half for patients who have negative CTs and negative enzymes and EKG. And the cost savings can be roughly 50% as well. And if you translate that out over 5 million ER visits per year, we're talking about somewhere between $12 and $20 billion in savings a year. It's very substantial. Just an example of a protocol that was taking this technique, and they randomized patients to stress nukes or to 64-slice CT, and they got a negative predictive value of 99% with CT, 97% with stress nukes. So it compares favorably, but the thing about CT is that it's available immediately. We can look at bypass grafts as well. They don't move much, so we see them well. We're looking for stenosis and for the issue of patency. Here's a Lima bypass graft going all the way from the subclavian artery down to the LAD. And here is a Lima graft coming all the way down to the LAD. But this patient also has, and this rotates around, has a saphenous vein graft, which you can see up front here, coming off the aorta and coming down to the right coronary. So there's both a saphenous vein graft and a Lima graft in this patient. And here, a saphenous vein graft that has a focal stenosis where it hooks into the LAD. We asked the question about patency for bypass grafts. The literature suggests very good sensitivity for arterial and venous grafts and specificity. Coronary anomalies is another issue for which we use cardiac CT, and it's definitely the test of choice for that. This is a young patient who presented with syncope, 14-year-old basketball player, repeated syncope during basketball games. And we did this and found that his left coronary arose, instead of off the left cusp, arose off the right coronary, passed between the pulmonary artery and the aorta, and during times of high blood flow, these two would squeeze this artery, and he got syncope. And this is the benign, this is the alternative anomaly. This is called the benign course, where the circumflex arises off the right coronary but passes posterior to the aorta, and this rarely has any morbidity associated with it. So after that brief run through, what is appropriate uses for cardiac CT recommendations from the American College of Cardiology? most recent set of recommendations: chest pain, low or intermediate probability, equivocal stress test, coronary anomalies, congenital heart disease, new onset of heart failure, cardiac masses, and before surgery that's going to be complex. Uncertain and under research areas of interest are chest pain with high probability, and we're going to start a protocol here for this in the near future, the triple rule out for which we have an ongoing protocol, Framingham risk factors of high or moderate as opposed to the low to intermediate categories, preoperative risk assessment in patients who are going to have stressful surgery, evaluation of cardiac functions or valves. So that's sort of the current status of the appropriateness of utilization. Thank you.